today. I apologize. Actually, that would mean if we could start at 3:20 and I'd be on Senate time. Isn't that right, Glenn? But you're not. Glenn's too busy doing something. We have 4 things on our agenda today. Assistant Commissioner Natasha Mers, thank you for being here. PCA to CFSS transition update. Then we got some folks that were going to come up. I think Vicki Garretts and Olga Shivaleva are coming up to talk about that stuff related. Is that correct? And Christy's shaking her head yes. Then we got Senate File 1175. That's a presumptive eligibility determination. Members, there's going to be an amendment on that one. And then finally, Senate File 985, Senator Maye Quade, there's a A1 amendment to that one as well. One of ours, the Senate File 1175, we're going to move that on to Senator Wickland's committee. I think she asked for that, so we're going to oblige. Unless you guys want to send it to Finance, Senator Abler, or send it to the floor, I'd be open to that one. So we can do that. So members, anything else you can think of? We're not. So Assistant Commissioner, welcome to the committee.
Thank you, Chair Hoffman. Members, for the record, my name is Natasha Mers, and I am the Assistant Commissioner for Aging and Disability Services at the Department of Human Services. I'm pleased to be here today to provide an implementation update for Community First Services and Supports. So just a little background here for the committee. Community First Services and Supports, otherwise known as CFSS, is our redesign of the Personal Care Assistance Program. The department moved forward along with external partners in making this reform and basically transitioning the personal care assistance program to operate under a newly available federal authority in 2010. So in many states, they launched the CFSS option only kind of one waiver authority, so one specific population and people and eligibility type. Minnesota elected to utilize or kind of bring in the entire PCA population into CFSS, and so had to, from an implementation perspective, launch it under a variety of federal authorities, which was more complicated, but we think worth it in the end in terms of overall program simplicity and giving people that receive PCA access to the substantial benefits that are offered under the Community First Services and Supports option. And I will touch on those in a few slides here. It has been a big, long, complicated project. We've been working on this since 2012 and working closely with implementation council, providers, and people on kind of the service design and how to work and how to implement it. We were finally able to receive federal approval under all those different authorities that you see cited in the slide here to move forward with implementation. That authority or approval was received on February 27, 2024. So just some numbers here to provide scope, scale, and impact. There are nearly 50,000 people that are using PCA services that could become authorized for CFSS once they convert. And there are approximately 900 PCA provider agencies that will transition to becoming CFSS provider agencies through this transition process. So wanted to talk a bit about why moving in the direction of CFSS versus the PCA or State Plan Authority was important for people in Minnesota. One of the biggest benefits is under the CFSS authority, parents of minor children and spouses of adults are eligible to be paid for providing support to that person and their family and their life. That option is not available under the current state plan PCA. It is available under the CDCS option in the disability waivers, but not for people that are only receiving those services. So that was a very substantial benefit for Minnesota and very consistent with what we've heard from community about expanding options for people to self-direct. And I'll walk through what that means within CFSS here in a minute. CFSS also provides different and more categories of service or things that people can do with their CDCS budget or their funds. One is worker training and development. So a person being able or an agency able to really understand and say, here are my specific needs and train workers to those needs and having a line item in the service to be able to do that. CFSS also allows for the purchase of goods or services from a person's CFSS budget, which is not allowed under the personal care assistance benefit. So when I say goods and services, in lieu of receiving services, a person could elect to purchase a personal emergency response system, or they could purchase goods or services that otherwise kind of reduce reliance on that one-to-one direct human assistance, which is sort of a feature and hallmark of the personal care assistance program. So there's more flexibility in people being able to choose how they want to get their needs met beyond having a person coming in and providing hands-on assistance day to day. The other benefit is access to consultation services. So this is a service that allows people to really receive neutral advice or consultation from a provider that's unrelated to who's going to be their CFSS provider, to help them understand and see the pros and cons for them on whether they want to choose a self-directed model where they get an annual budget and they act as the employer of their workers, and therefore they're writing their plan, determining training requirements, things like that, or whether it's better for them to, in their circumstance, to go with an agency model which operates a bit more like a traditional PCA, where that you get a number of units of service and you work with the agency to find your staff and write your plan, and the agency takes care of a lot of that work. So both options are available under CFSS, and both really important options for people that are gonna, which option a person goes with is gonna very much depend on their circumstances, their life, what they want, where they wanna spend their time and energy. And the consultation service provider will help a person walk through those different options and make a choice about agency versus budget model, and then also help them write their plans so that their expectations and their needs are being met within that written service plan that's required. So a little bit more about consultation services. We have 18 providers currently enrolled and 10 additional interested providers. Those numbers have been updated recently, and so I will make sure that we get that information to committee. The consultation service provider lack of capacity certainly is a hurdle that I'll talk through in another slide. That RFP is open, and so DHS is also actively seeking additional providers for consultation services should they approach the department and meet the qualifications and be interested to move forward. So talking about the experience of people navigating this system.
Natasha.
Yes.
Senator Fata.
Thank you, Mr. Chair, and thank you so much. So out of the 18 currently enrolled providers, do we have an idea of like the geographical locations?
Mr. Chair, Senator Fata, yes, we do, and we can get that information to you in the committee.
Awesome.
Follow up.
Thank you. Are there any known like gaps in locations that are not being met?
Assistant Commissioner.
Senator Fata, what we do know is that demand is exceeding capacity across Minnesota, and we're working to address that through the open RFP and really trying to enroll providers as quickly as possible so that people can receive those services. It's important to know that consultation doesn't have to be in person. Those consultation can happen in different modalities, and so certainly having access geographically is important. In this particular circumstance, there is flexibility in terms of statewide access.
So Assistant Commissioner, let me just, demand is far exceeding capacity. Can you go down that little rabbit hole? What, meaning there's not enough providers, not enough workers? What's the thing that's driving that? If you could clarify that. And if I can I go ahead and ask that? So go ahead.
Chair Hoffman, members, I was referring specifically to the consultation service provider. So one of the requirements within CMS in our waiver plan is the service design is that people access and have a consultation session before they convert from their existing PCA services to CFSS so they can make that informed choice. And so it's just taking longer.
Did you hear that, Senator Ayler, the word informed choice? Do you remember when we put that into law?
So I don't know.
Senator Fata, go ahead.
Thank you, and thank you. So I think you mentioned neutral third parties. What is in place to ensure that folks that are influencing hundreds, if not thousands of folks remain neutral?
Assistant Commissioner.
Mr. Chair, Senator Fata, thank you. That's a really important question. I'm happy to address it. So there are sort of neutrality requirements within the consultation service provider agency. One of the most important ones that I think addresses the issue you're raising is that a consultation provider cannot be both a consultation provider and an agency to the same person. So they might provide both services, but they cannot provide both services to the same person to avoid the perhaps temptation or the idea of, okay, you're choosing, routing people from consultation directly to the provider. That approach, while we think it's very important and is required in terms of the CMS service design, does limit capacity, right? So those are trade-offs in terms of the workflow and the number of agencies or, that a person has to touch before they become enrolled. So.
Thank you. We're going to go to Senator Gruenhagen. This is a great conversation. This is like my head's spinning right now, Assistant Commissioner. So Senator Gruenhagen, to that point.
Oh, thank you, Mr. Chair. Yeah, thanks for your presentation. Yeah, I have a nephew who has PCA service, and they're very satisfied with it as far as I know. At least that's the input I've gotten back. So you talk about, getting new providers. Do you put them through some type of vetting process? Do they have to be licensed? Is there a cap on administrative fees? We seem to have a problem with some of that in other areas, and so if you'd like to respond to that.
Thank you. Assistant Commissioner.
Mr. Chair, Senator Gruenhagen, yes, happy to respond to that. So for personal care assistance agencies that are currently providing the PCA service, PCA and CFSS is an unlicensed service, but they are required to meet the Medicaid enrollment requirements, including going through revalidation with provider enrollment. And there are many programmatic integrity protections in place in the PCA program that have and will transfer over to CFSS. So we're keeping those important components and converting them over to the CFSS program design. So agencies that are currently providing PCA services will become enrolled as CFSS providers, and the program integrity requirements that accompany being a PCA provider will follow them or translate onto their new agency role as a CFSS provider. So that's for existing provider agencies providing services. I also want to address consultation services, which is a new service in Minnesota. That's kind of the suite or package of services available under CFSS. So consultation services is an unlicensed service, but they are subject to enrollment within the Medicaid enrollment requirements. The requirements are different than they are for PCA agency providers, or they may be different, and happy to provide more details, a follow-up if needed on that. The consultation services providers are also under contract with DHS, so we have a second layer of oversight in that case. We have contracts with them to be able to have a more, I'm going to say, agile mechanism. If we are finding a consultation provider isn't, following CFSS requirements, isn't meeting program integrity standards and things of that nature, then we can use the contracting process to address that in real time.
Wow, thank you for that. And I suppose to Senator Gruenhagen's piece, when the training that goes on, it's pretty intense. They go through everything, and it's, so they're going to keep that congruent, what's the word I'm looking for? Glenn, I can't do this. Follow up, Glenn, go ahead. Congregate, yes.
Thank you, Mr. Chair. Yeah, thanks for that, President. The other part of my question was, is there a cap on administrative fees for these providers? I mean,
probably 2%. There's not much room for, yeah, that's a good question. Assistant Commissioner, do you know the answer to that?
Mr. Chair, Senator Gruenhagen, within the existing PCA and CFSS structure, we're in a program transition time, but again, many of the rules, program integrity rules for PCA follow along to the CFSS provider. There is a requirement in statute that 72.5% of the rate received, I would maybe ask someone to check make sure that number is exactly correct, but it's in the ballpark, are required to go towards wages and benefits of the direct support professional workers. So there is that requirement in state law. And specific to consultation services provider, there is a per session fee that providers charge, and people are allotted 6 sessions of consultation services. They can add more, but they have to go through an approval process to get more sessions added to their support plan.
Okay. Isn't that awesome, Glenn? Don't you think the rest of the state would operate like the Department of Human Services? You'd have that answer. Senator Abler.
Well, thanks. I was going to wait with my questions, but since we've taken a little siding here, looking at the monuments. I've got a number of questions, Mr. Chair. And I think, actually, I'm suddenly very concerned how this is going. The training time for one of these consulting personnel is how long? Like a week or something?
Assistant
How many
Commissioner.
hours?
Mr. Chair, Senator Abler, the training is substantial, but I would like to go back to the team and get you the specific training requirements and kind of what a consultation provider needs to do in order to become qualified. And some of those requirements are likely laid out in the contract, but I'd like to provide you with more information.
Yeah, well, I wasn't, it's meant to be an easy question. And so once you get going, what do we pay them? How long is the consultation? 1 hour, 2 hours per session? What do you think?
Assistant Commissioner.
Mr. Chair, Senator Abler, it is the consultation, it is by session, so it's not so much a time limit, but characterized by the activity that's needed to accomplish the thing. So a session could be, for example, with a person coming in new, having an informed choice conversation where they walk through the pros and cons of an agency model versus a budget model, and those are $100 per session.
$100, all right. All right, and so it could be 10 minutes, it could be 2 hours. Right.
That's
anyway,
correct.
yeah, sure, I got it. And so are we doing CFSS now? Mr. Chair.
Mr. Chair, Senator Abler, yes, we're in the midst of implementing and transitioning people at their annual assessment date from PCA to CFSS.
Did it start like in October or something, or when did it start? Do you know?
Mr. Chair, Senator Abler, I believe it was either September or October, but we can double check the date.
Yeah, it's close. I'm just trying to get the ballpark here. And so how many, this just has, with all respect, and there's two of the most caring people sitting at this table.
Yeah.
This has got just red flags all over it. I mean, the $100 is probably not enough to have some agencies even want to do this, to go through all the training. And everything costs a lot. But so you're going to have people making net $30 an hour doing this. They have to an agency, there'll be a supervisor. I was just talking to some people that do management, they do the online, some county people came in there. Like they do this and they got a supervisor, and the whole pyramid has to be paid for by the services provided by the direct workers, because they get so much, the case managers that we're talking, they get like $96 an hour for a whole hour of it. And they need a raise, Mr. Chair, so does everybody. So how many of these providers do you think you're going to need when you get all the ones you want? You must need, you have 50,000 people. You must need 1,000 of them?
Assistant Commissioner.
Ms. Mertz?
Mr. Chair, Senator Abler, yeah, that's a great question. It's a hard question to answer. We're certainly in a period of time with our initial implementation where demand is as high as it's ever going to be as we move through implementation. So we certainly know that we don't have enough today to meet the demand and need for consultation, which is the reason that we have kind of an open RFP and are actively working to recruit and train new providers. I think we will need to assess after the full transition has been made. We'll need to really talk with our consultation providers, take a look at the metrics and the time, hear from people, and try to understand through that process what the ideal number is. I will say that what the department and what my team has been trying to balance is consultation is a new service in Minnesota, so we don't have the benefit of hindsight to figure out what worked and what didn't work. We're in that process today as we implement. And we also want to make sure that we have a provider pool of consultation providers that are qualified and really good at doing what they're doing and can be in close relationship with DHS in terms of making sure they're meeting new requirements, that they're providing the training and information that people deserve in terms of informed choice. So it will be a process to figure out and understand that as we move forward and kind of settle into implementation. Right now, we're very focused on getting people access to the services they need and making this transition go as smoothly as possible and address the hurdles that we know are here and that we've heard about from providers and people.
Well, thanks, and I'm not going to belabor it, but it seems like maybe a person, if they're a consultant or what do you call them, could maybe get through 20 of these sessions in a week or something, especially on the first one, because these people are like, have no idea what's going on, and I'm not even sure if the depth of knowledge of these people doing the consultation, is that the word, consultations?
Yes.
Whatever they're called.
I couldn't get that other word,
consultation.
congruent out. So
They actually help.
Yeah.
So, I mean, so if this started in October or so, we're already a third of the year through exposing a third of the people. You've already been through 16,000 people to be served by a couple dozen staff. So in the meantime, and maybe it'll work well, but I just suddenly I'm concerned. No one's got a hold of me. Usually they do, but like people that can't find somebody for they're 70 and they got this 45-year-old kid that they're worried about, not a kid anymore. And they were a January group, and now they're supposed to have this squared away. And in the meantime, if they didn't find one of these people, and in that case, maybe a veteran 70-year-old by now, they've been through a lot of this, are they going to get to keep their same providers and do the same services? Does somebody has to approve a different budget now? What happens to that family who has no way to access one of these people?
Yeah, Assistant Commissioner.
Mr. Chair, Senator Abler, so if I understand your question, you're asking about a person who's been using PCA services for many, many years and is having difficulty accessing a consultation service provider because and then what happens?
Yeah, so that they were supposed to re-up on January 1st and they can't find one. What happened? Are they just continuing with their old level of service so that nothing will change for this family?
That's correct. For people that have had delays in the transition due to lack of consultation or other factors, we've added an automatic 6-month renewal of their existing services to make sure that people don't experience a disruption in services, those day-to-day services. Okay. So that's one thing that we've implemented to smooth some of the hurdles. I will say, for a person that has been using existing services for many, many years and is satisfied and happy with them, they can go through consultation services and make exactly the same choices that they've made up until that point. They can choose to stay with the agency and do an agency model. They will be offered and offered opportunities to understand what that other model could look like and what the benefits are. But the benefit of having that neutral consultation services provider is the consultation provider doesn't have any incentive in the outcome. Their incentive is to create a good relationship with the person and give them the informed choice. And often people that are satisfied with services make the informed choice to continue right along that same path. And that's a great outcome.
I know, I get it. And I don't want to drag this out, but I can just imagine there's a lot of families pretty worried. And I don't even think by the time July comes for this family I just made up, that there'll be enough to go around. And so when you made the decision to have a 6-month extension, Mr. Chair.
Senator.
Was that an administrative decision you got to make at DHS, or did you have to get somebody to approve that somewhere else? And so when 6 months goes by again and they didn't get one, like the October people, I can't imagine all of them have even had a chance. So they're going to be coming up in, March or April or something. Do you have the authority to decide that again? So there's a couple questions there. Did you think of it, or who can think of extending it more?
Assistant Commissioner, I know, Jimmy, I love this.
Does that make sense?
Yeah, no, it does, and I think, you got.
You mean well, but no.
Maybe it'd be nice, this is like an open discussion on this, I think, while you were talking, I could see Vicki Garrett shaking her head yes and no on a couple of things, so it'd be interesting when she gets, maybe she should be up here, because that becomes the dialogue, the what if,
Yeah.
We know why we stacked it, why did we set that up for that, is it working, how you doing, how you assurance, that's all it is, and Natasha.
So my question is about how to, like, if you need more, did you have the authority to make up your first extension for 6 months? And if you need another one, can you just keep going and letting people be served? These people are happily being served. They've had a life of great challenge and endured so many improvements along the way, min choices, and so many other things that have come on. And they know what their family needs and wants, and they want it to be just the way it was. And maybe they're open to some new ideas, but they're probably happy when you're 70 and 45. You're pretty well locked into the thing with your person who's been the same. Every assessment's been identical since they were 6. And so what happens? I just think so tell me how can the extension thing goes, and you can tell my concern is we're going to unsettle some people that are doing fine.
I think the other thing that comes up too is I think part of the slides might get into that same conversation.
That's why I was gonna wait.
Well, I know, it's like you wanted to wait, and then it was like, no, because Glenn had to ask his question, so
Glenn.
there you go. We're going to blame you, Groening.
So asking my question.
No, you get, and Natasha, thank you. That was actually a good conversation, because this is what we struggle with about when we transition, how are you going to stack it? Do you do it all at once? Do you do it? I mean, that's all it is. I see that. And I think ultimately, I think, Jim, we're going to have to find more money. You know, we're going to have to appropriate some
we need
money.
more. There's not-
So anyway, go ahead, Assistant
This is going to
Commissioner.
answer my question.
There you go.
So,
Oh,
thanks.
EMQ's got a question first,
No,
sorry.
I had a question already. So
Oh, you
just, he was
did?
going to tell me about approvals for, about extensions for the future and that
Yeah.
question.
Oh,
So I'll restate my question.
you restate your question.
So you decided to give a 6-month delay, which is a good idea. And then if you need more delay, can you do that too? That's my question.
Mr. Chair, Senator Abler, I think I would just want to clarify that it's not a delay in the sense of it's just a person that's, we're sort of, if they're not able to access consultation in time to be able to continue services that they're able to continue in our Medicaid systems and our IT and service authorization systems, that they have the ability to continue to receive services and the provider is able to continue to bill under the PCA, you know, HIC codes and things like that. So that's what we've implemented. I certainly think that, you know, there's a possibility to look at that again. I think we'd want to go back to the team and make sure we understood all the details and, you know, what the requirements of our waiver plan and other amendments are. I think the most important message here is that we understand that there have been some implementation roadblocks and hurdles that we're actively working to address, and we are and will continue to work with provider organizations and lead agencies to make sure that the process goes as smooth as it possibly can, and that the core value and the core outcome that we're, you know, kind of our baseline here is that people don't experience a disruption of services while they're making that transition.
That's fine. I want to hear Senator Maye Quade's question.
Senator Maye Quade.
Thank you, Mr. Chair. I apologize if this is a repeat question because I was reading and catching up while some of the speaking was going on. So the consultation services is a requirement to continue. And I'm glad you went to the next slide because it says a person is authorized to receive 6 sessions of consultation services. That seems like a lot to me. What does that look like?
Chair Hoffman, Senator Maye Quade, thank you for that question. So there's a variety of functions that we ask our consultation services providers to provide for people. The first is an informed choice conversation about whether a person wants to utilize the agency or the budget model within CFSS. So an agency model looks a lot like our traditional PCA program does look today, where the agency is the employer of the direct support professionals. They're required to do the training and then work with the person receiving services to, you know, do further person-specific training. When you want us to come, how do you like your services to be received? What are your expectations? Things like that. In the budget model, the person using services, the budget model is a purely self-directed model, which means that if a person makes a choice to go to that model, they are acting as the employer of their direct support workers, and they access services like financial management services and other things to meet their legal and compliance responsibility as an employer, payroll, taxes, wages, all that kind of stuff. So the consultation service provider starts with working with a person to have that informed choice conversation. You know, what are the benefits of the agency versus budget model? What are your life circumstances? What are your goals? How do you want to get there? What's going to best meet your needs? Staying with agency model, making a different choice, or maybe you want to stay with an agency model, think about it, and come back and make a different choice later, that kind of thing, and kind of what that looks like. And then another example of a function a consultation service provider is helping a person write the plan. So in particular, if they choose a budget model, they need to, as the employer, write the plan for themselves and for their workers. And so that interactive process and teaching people how to write plans that can be approved, that are, you know, approvable by Medicaid or by the lead agency, is another example of things a consultation service provider might provide.
Senator.
Thank you, Mr. Chair. Thank you for that. That was super helpful. And is this part required by CMS, or is this a requirement that we put into place?
Assistant Commissioner.
Chair Hoffman, Senator Maye Quade, my understanding is that this is a requirement of the CFSS authority that the program is authorized under. I do want to maybe double check with my team to confirm that in terms of a CMS requirement. So let me circle back on that particular question, but.
Yeah, it's a great question. Do we typically, when we make changes, don't you have to get authorization from CNS on that? I suppose that would be good. Actually, if you could let the whole committee know on that one, because I'm always confused. Why did the state of Washington was able to do things without having to get authority? Because what's how they set their Medicaid director system up. So, great question. Senator Maye Quade.
Thank you, Mr. Chair. And yeah, I think one of the things that happens is that we hear about a program or things that are happening, and you're like, I'm passing along information. Gentlemen, are you good? You pass along information to us about how it's set up because it's required by law, and then we're like raking over the coals for a thing that you're legally required to do. And so I want to make sure that I always know the difference, so I'm not like grilling you about why are you doing this, and you're like, because we have to. And so that was mostly the motivator for that question.
Did you get that question out? Because I heard the
peanut gallery?
The peanut gallery over there was
Yeah.
being loud about something, so that was good. I think we're good. We're giving you a hard time when Abler walked by, Senator Rodriguez.
Let's see a new slide, Mr. Chair.
Let's go to a new slide. Thank you, Assistant Commissioner. And what we're having up here, though, is there's some discourse about, did we do this right? Are we doing it right? And I'm sorry, but go ahead, just keep going on your slide. Thank you.
Mr. Chair, members, so just thinking about what would be the most helpful here. So I think one thing I want to circle back to, also following up on the good question Senator Maye Quade answered, is one requirement that CMS required of us that wasn't in our original program design was having the lead agencies approve the plan once it was written by the consultation services provider. We sort of designed and thought that it would be acceptable for a consultation services provider to approve the plan and say, yes, it meets requirements because of the different oversight mechanisms we designed within that service. CMS was very clear with us that it needed to move into a bucket of services called an administrative activity, which requires the lead agency to actually sign off on the plan and approve it. And we understand that that has created a lot of touch points between provider agencies and lead agencies, a lot of handoffs, which has created complexity. And so I think we have, work to do, with our partners to figure out how can we make just the process of moving through consultation more streamlined and meet the federal requirements that are necessary to maintain compliance. So wanted to just be very transparent here and acknowledge that we have had implementation challenges, which, for us is a part of implementing big program reforms and expected, but we also recognize that when an individual person experiences a hurdle like that and they get concerned about the availability of service, that is a very serious problem that we need to be attentive to, both as a department and as in partnership with our provider agencies. So I've talked a little bit before about the consultation provider capacity, that there is more demand for that than current capacity in terms of the timelines that we want to see. And so, as I mentioned, we do have an open request for proposals and are actively onboarding new providers as quickly as we possibly can. So that is an effort we've made to address that concern. We've also been in regular, we have sort of regular office hours with consultation services providers to be checking in, quasi real time, what's their waiting list look like, what are their capacity needs, can we clarify policy guidance or things to make that consultation go smoother for them so they feel more confident relaying information to people. We have also had some barriers in getting agencies enrolled into CFSS, so we do have to do a kind of an enrollment process to convert them from their existing PCA enrollment to their CFSS provider enrollment, and that has been slower than we expected. And I think one of the, not to get too far into the weeds, but one of the things we were doing was trying to combine the revalidation process with CFSS enrollment, and that is proving just too complex, too many forms, too many things to keep track of, and was really slowing things down. So we are working with our partners in healthcare to really streamline that process and prioritize getting the PCA transition, PCA to CFSS transition, and have made significant strides in terms of the data and number of providers enrolled, but we are kind of operating from a backlog, so we need to stay very vigilant and monitor those numbers on a daily and weekly basis, which is what we're doing to make sure we're seeing the steady growth in enrollment that we need to overcome that backlog and move through implementation. So I talked a little bit about PCA revalidation. We also are facilitating more training and technical assistance to provider organizations and lead agencies. What I mentioned before is that we know that because of some of the administrative complexities that CMS required, we do have a lot of touch points, a lot of processes, a lot of points and handoffs between plans and authorizations, and that is creating barriers. And so we have work to do to figure out how to streamline that, but we've also upped our provider support and technical assistance so providers understand what's required and how to move things quickly, and that lead agencies understand how those things interact. And of course, lead agencies are very busy with all of their lead agency functions, so we're trying to be very sensitive to that and offer both support and them opportunities to tell us what's not working, and then we see within our existing authority, what can we fix or refine, either through training or some type of policy clarification. So we are making steady progress in overcoming these hurdles. We do have a road to go, and we'll remain vigilant in monitoring the data and metrics and meeting with our external partners to check in and see how things are going and make sure that we've got the right touch points in place.
Thank you. Senator Maye Quade.
Thank you, Mr. Chair.
Then Jim.
I guess I'm reading this and thinking RFP makes me think of more money. And so is this costing more because we're adding in the consultation services, third-party people to be engaged in these services? Is it, or we already paid for that in other budgets? Because you've been doing this since 2012, so.
Here comes Elise. Miss Bailey,
No, that's okay.
come on down. Well, you know, the other thing too, Senator Abler, I remember when we originally were talking about this, right? The consultation services is good policy because many people on PCA don't get case management because they aren't on a waiver. Is that correct? And so that change creates that more equity across the system, right? I mean, that was the intent of that, especially that support people with disabilities. I don't know if it's so with that. Ms. Bailey, welcome to the committee.
Hi, Chair Hoffman, Senator Maye Quade. So the implementation of CFSS in general as a whole will result in actually a savings to the state because we're pulling down an enhanced federal match for the majority of the population. So even if we're adding this one kind of service that's a pretty small proportion of the total spending in CFSS, it's far outweighed by the amount of savings we're getting from the additional match. Don't have the numbers in front of me, but generally that's how it will play out.
Thank you, Mr. Chair. I'm so glad you're here. How long into the future until we start seeing that show up on budgets?
Ms. Bailey.
Chair Hoffman, Senator Maye Quade, we're already anticipating those savings as folks are enrolling and have gotten those consultation services and they're billing CFSS. We're already anticipating in the forecast that that we would pull down that enhanced federal match. I would say, though, that implementation is phased in over time. And we are kind of assessing as we update our forecasts on how that implementation is going and what the timeline is.
Thank you.
Senator, we're good. So going with that, and as long as you're here, please stay here, because I think Senator will probably do it if I can, that any changes, if you look at the hurdles that are here, there are any changes in this area, are they reflected in the February forecast? And if so, how much is in that, do you know?
Chair Hoffman, I cannot share that at this time until after the February forecast is updated, but between November and February, of course, what we're doing in that period of time is we're pulling new claims data and then we're updating the forecast. So generally, any new information that we have, we do incorporate it into the February forecast.
Thanks, but no, thanks. No, thank you. I appreciate. No, it's a question because it's like, all right, so here's this piece of it. There's going to be some changes. Are they reflected? So let me ask this first part of the question: are the changes reflected in are they reflected? Are the changes reflected in the forecast? Can I ask you that question, or is that an unfair question?
Chair Hoffman, the current forecast, so the November forecast does anticipate us implementing it on the date of, I think, October.
It does.
Yeah, October through March is
Okay.
what it assumes. And so what we are assessing in the February forecast is if there's slower take-up of consultation, what does that mean to claims? And it might mean that the forecast changes, I don't know. We're
Okay.
currently assessing that, but it would likely, even if there was a change, it's such a, like I said, such a small proportion of the services.
Okay, thank you for answering that. So Senator Abler.
Well, thank you, and I like talking about forecasts. Yeah, and I think it's, just what you told us, Senator Hoffman, I think it's going to be a slower uptake, and I think that the forecast will pay for it, but that'll actually deepen the deficit. Yeah, that's my dollar. You can, we'll see. And so, so I just, I was spending some time in the back of the room, and there was a, well, I'll just say there's a deep concern about this whole thing. They use stronger words. And so then there's no pejorative here to be, nobody's fault. It's taken a decade or longer. And so why would it go smooth on the front end? But we talked about the consultation providers. I just want to point out, I don't know what they need to know, but if they're going to do a really good consultation, 10 hours of training is not going to do it, I don't think. And you can't use existing providers who actually know all this stuff. And so you get people who are stone cold to this topic who are going to want to take up a job that gets them $100 an hour that they have to have help with and administrative support. So I'm just concerned that to find enough people who are willing to do that and actually be good at it. The IRS helpline, when you call them, they don't stand by their advice. You know that? And so, and then you make a decision, and you're like, well, the helpline say, well, they don't know what they're doing. Okay, thank you. Here's your audit. And so I'm concerned about what we have all hoped for all along, where there's going to be a greater engagement, the personal choice, and all that business. And so then so I'm curious if you could tell me, you probably don't know right now, but how many people of the 50,000, so you would have had about 16,000 people trying already through February. How many of those 16,000 people whose time has come up have been successful in having a consultation and having their new program approved? Do you know that, or if you can get back to us, that would be nice to know.
Assistant Commissioner, do you know that answer to that, or do you want to get back to us on that one? Because that's.
Mr. Chair, Senator Hoffman, on the specific number of people having gone through consultation, we'll get back to you with that information. What I'll say, Senator Abler, to address your comment prior to the question about the numbers is, who's going to do this and how do we know they're good at it, right? That they're providing the level of quality that we expect. And what's their training requirements? I would certainly refer you to the request for proposals that we have out there in public, or we can certainly send you a link that will lay out the requirements for becoming a consultation services provider. Yeah. So an agency can't get into the business and, unless they provide adequate responses to those requirements within the RFP that lay out those things. And then there are other protections and other sort of things we've done in terms of training that I'll need to get back to you on in terms of details. But I think one of the reasons that we've continued to have a contracting process in addition to the provider enrollment is so we really have a very tight contact with those providers to be assessing quality and making sure that they maintain the qualifications that they provided to us in the RFP. So an agency can't get sort of through the door unless they meet those pretty substantial requirements.
No, I get it. And so we've discussed over the years about separation and who can tell who to do what, and I get that, and I wonder if there are that many unethical providers that would mislead somebody, that having set up all this rigor to avoid that, we're avoiding some good people who actually could give good advice that actually know. There was even a time in the min choices that the provider was not even allowed to comment to the choice person, as I recall, and we had could at least listen to what they know, because they've been working with this person for perhaps 20 years. And I don't know where that ever landed. And so you're approving, how many providers are there that you're trying to get through the CFS approval thing? You're at the 320 according to your chart, but how many are left?
Chair Hoffman, Senator Abler, yeah, there are 900, or approximately 900 agencies overall that need to make the transition from PCA to CFSS.
All right, so if a person who came up in January, this 70-year-old woman and their 45-year-old kid had the consultation, they've been happy with their provider who has not been able to be approved yet in CFSS, what happens to them?
Mr. Chair, Senator Abler, so that is where that 6-month authorization of the PCA services comes into play, so they don't experience a disruption in services.
Got it.
So they just continue with their provider, so they're kind of a hybrid sort of a thing.
And does that, and that's where that other series of questions came up too, that you were asking, well, what happens if, yeah.
Yeah, well, this is a different. So,
Yeah.
So you're only 2/3 of your providers are approved. And so how rigorous, so you've had a person who's done a PCA thing for a long time, and they're trusted, there's no, for all the fraud discussions, they're like an exemplar, you use them for a case study. What do they have to go through to get approved to be a CFSS provider?
Assistant
A
Commissioner.
check a box, or do they have to go through a phone book or the stuff?
Mr. Chair, Senator Abler, let me get back to you and make sure I'm getting you accurate information about the requirements to make that conversion. I don't have that information at the top of my, tip of my fingers.
Mr. Chair.
I know, I was just
Oh, yeah.
thinking, if you'd have been looking at one of the slides, DHS increased technical assistance via the news message and direct messages into the minutes mailbox. Do you remember when you asked how many people, do you remember that? It was here. That was like 5 years ago, 675. You said you could post so many. Anyway, I had a moment of lapse on this, having this conversation. So do you want to get Vicky up here, or what are you thinking? Or you want to keep, I mean, where are we at?
Well, I don't
with
know,
this?
just a comment. We make
No, you're
everything
good.
hard. We make everything hard. We make this person who's had the same condition since they were 6, and now we're min-choicing them, and they make them go through our grueling process every year. We tried to make it, well, less, we tried to skip a year, like, hey, same as last year, check a box.
What happened to the checkbox?
And I don't think we succeeded with that.
No, we didn't.
And so we have counties that don't have staff, that are using subcontractors who do not respond to the client, and who offer differing levels of opinions depending upon who the employee of that subcontractor is, that the county doesn't feel a responsibility for overseeing them, and there's no place to complain to. And now we're adding a whole, that's just going on now. And I'm not mad at you, I'm just like, we're spending, and so then we have this thing here, and now you gotta get a consultation from somebody who knows less than the mother who has been sitting through this stuff, to approve the child, 45-year-old person, who's just wants to be home, or wants to go to their Achieve Center, or do whatever they want to do, the way they just did it last week, and they don't handle disruption well. And you got the provider that they've got says, well, good news, we can still keep using us because we've got a few months of window left until we can get through this proposal, until we get reapproved with a 16-page application that pretty much says you're still good. And can't we make it easier? Can't we? And so then we have a governor who says the reason for the deficit is because they're spending too much money on people with disabilities and autism. And I think that we are on the wrong track. And so you two, the three, are just amongst the more committed, knowledgeable human beings in the state on this topic, and you go to bed worrying about it, and you wake up worrying about it. But can't the people here who care so much get our minds together and make it so it's simpler, and it could cost 20% less, and you wouldn't have to worry about it affecting inflationary rates and all that? And I don't know, you can comment or not, but
No, I love it.
I've been in this chair
20 years.
26 years, Mr. Chair.
26 years.
And I feel like I haven't accomplished anything. and so, and Mr. Chair, is similar for you. And so, I don't know, I mean it well. And can we, before we get to June and look at a shutdown and worrying about how we're going to get a continuing resolution to freeze something or other to get by here, can't we find a better way? And in this committee, with the people who are so committed, find a way to convince you and the Legislative Budget Office that there's some ways to do this stuff a little better, and say it doesn't really matter.
That's your point. You know, years ago you said that. I don't care if it's a good, come and have that conversation. How can we make it better? I mean, we had this conversation it's 8 years ago, Jim. I remember that.
Yeah.
That's to your point. This is where we're at now, and it's like, I'm glad this conversation is
And
happening.
I'm almost done.
I
And
know,
so-
no, I just
Yeah.
want to say, this is what this is about, so
Yeah.
keep going.
Well, no, I just,
Here.
I mean, can't we apply to CMS and say, really? Look what you put us into this spot. We're about to not pay nursing homes enough to keep themselves open. We're about to disrupt so many operations. You know, we're looking at at $3 billion of impact with what the governor has suggested with $1.5 billion over the 4 years times 2. And I got to think that reducing spending by $3 billion in this arena is not going to make it easier for that mother and her son. And when it doesn't have to be, it's not hard to find $1 billion over 4 years if you can do it thoughtfully. And so I'm just, I don't know, we're all here for that. So that's all. Please take it in the best possible way. That I just am begging for your help, actually. I'm
You
done,
were-
Mr. Chair.
But, thank you, Senator Abler. There's nothing personal about that. It's about the commitment and the passion that you have about what we're doing. This guy, we always get to the why. Why do we do what we do? This is why we do what we do. This is what the questions that you're putting. So, thank you, Commissioner Fata. No, Commissioner, thank you, Commissioner Fata. I did comment, or is it a semicolon? The good senator from Minneapolis. You have 2 minutes.
Thank you, Mr. Chair, and thank you, Commissioner. You're talking a bit about the delays in enrolling the 900 CFSS providers. I guess my question is, when did the enrollment process for the providers begin?
Assistant Commissioner.
Mr. Chair, Senator Fata, that process did begin as soon as we started implementing the entire program. I think what I mentioned before is we had originally combined agency revalidation, those standard Medicaid revalidation requirements, with PCA enrollment or CFSS enrollment, and found quickly through feedback from providers that it was a very confusing, it was too many papers, it was too many things at one time. And so really took a look at and streamlined the process to prioritize that agency transition, and have been making steady progress at increasing enrollment numbers much more quickly than was happening before, and very, grateful and heard the feedback from provider agencies about what was definitely not working in early stages, and have worked to respond to that and make the process improvements needed to get those numbers up. And we still have work to do and progress that we still need to make.
Awesome.
I have a second part, I can wait.
You want to do it? Because we're going to go. Thank you to Assistant Commissioner. Thank you. I really wanted to say I appreciate your knowledge about this, how the systems work, and the passion that we all have in this same. At the end of the day, we want to do what's right for the people that we're counting on, and it's a real struggle up here. And so we appreciate you being able to dialogue and have that conversation. So. If you want to stick around here, Vicki, you want to come up? Vicki Garretts, and then Olga Shavalieva. Are you coming up too? So unless we can get another chair, you're going to go. Christy's going. Okay. Yeah. And I think you're fine. You can. It's fine. Come on, Olga. So, Vicki, I saw your head shaking yes and no on a couple of times when Senator Abler was revisiting, and I thought, all right, so there's something in her presentation about help us understand how it works from a provider perspective, and you're with the Minnesota First Provider Alliance, so for the record, state who you are. Thank you.
Thank you, Chair Hoffman and committee, for the opportunity to share the provider's perspective on PCA to CFSS transition. My name is Vicki Garretts. I'm a board member of the Minnesota First Provider Alliance. The Alliance is an association for PCA, CFSS, and waivered service providers in Minnesota. I also provide advocacy and policy support for 2 culturally specific PCA, CFSS agencies who are also members of the Alliance. I'm not here to go into great detail of the multiple issues regarding this transition, as the Alliance has already sent several letters to DHS, the Governor, and Human Service Committee chairs. There's many players in this transition, the most important being the people who receive the service. There's also their families, their workers, agencies and consultation providers, case managers, managed care organizations, assessors, and fiscal management providers. Our greatest concern has been the lack of consistent information and communication with all of the parties involved in the service. This has resulted in confusion for the people who receive the service. As a reminder, there's 47,000 people on the PCA program, and 63% of the people who receive services are Black, Indigenous, and people of color, many of whom English is not their first language. Change is hard, and CFSS puts more responsibility on the service recipient. They transition from PCA to CFSS at the time of their annual assessment. At their assessment, they're to be given information about CFSS and the list of consultation providers. They are then to select a consultation provider from the list of 18 current providers and contact one of them to schedule an appointment, and then notify their assessor of who they selected so that assessor can issue a service agreement to that consultation provider. This is proven to be very difficult for people, and even harder when English is not their first language. Some assessors did not tell them about CFSS or give them the list of consultation providers, and it's a struggle for people to get appointments, as there's not enough capacity, as the commissioner talked about. Some consultation providers are scheduling appointments a month or two or even longer out. Some are at capacity. Agency providers, we try to help as much as we can, but we have to remain neutral. DHS received approval from the federal government to start CFSS on February 27th, 2024. Many of us were in this very room when that announcement came in. The transition started on October 1st. All 946 PCA agencies needed to enroll as a CFSS agency, but agencies were only provided with the information in the forms needed to enroll in mid-September. As of this week, 320 of the 946 providers have been coded as a CFSS agency. Participants who were the first to start transitioning to CFSS were told by their case managers, you can't stay with your same agency because they're not coded for CFSS. This was devastating for people who had long-term relationships with their provider, especially when they had culturally specific provider who spoke their language and honored their customs. DHS should have been working on enrolling providers months before the start of the transition, or lead agencies should have been given information about why providers might not have been coded, and that it did not mean that the client had to select a new provider if that was not their choice. Lastly, DHS has held office hours for some of the key stakeholders, but only started having office hours for providers this past month, despite the transition starting on October 1st. The lack of getting all involved together and providing clear guidance for everyone has created so much confusion, and the people who are suffering the most are the service recipients. Thank you for the opportunity to testify, and I am open to any questions.
Thank you. And for our next testifier, welcome to the committee. Please state your name for the record and proceed with your testimony.
Chair and committee members.
I'm sorry, would you please speak into the microphone? Just if you pull that up to your mouth. Thank you.
Is this better?
Yes, thank you.
All right. Chair and committee members, thank you for letting me testify on behalf of CFSS Consultation Service Agencies. My name is Olga Sheveleva, and I'm the Vice President of Development and Strategic Planning at Metropolitan Community Services. Our agency is a nonprofit, multi-specialty essential community provider serving around 380 people in our PCA CFSS agency program and around 500 people in our CFSS consultation program. We are a culturally specific provider, and we specialize in the Eastern European population. I'm also on the policy committee for the Minnesota First Provider Alliance and am a board member of the Minnesota Home Care Association. As a CFSS consultation agency, we provide education to people about the CFSS program and its models and assist people in writing their service delivery plans. We are off to a rocky but successful start with helping people pick appropriate model of service and helping them write their plans that are getting approved and resulting in authorizations to begin their CFSS program. We greatly appreciate all the guidance and support from the Department of Human Services and our collaboration with all the lead agencies from every county. Unfortunately, there still are barriers to access consultation services for the people we serve. Those barriers are caused by limited resources for adequate workforce recruitment and retention and the need for significant supporting personnel and oversight to provide quality services. Our agency currently has a 2-week waiting list to schedule a consultation service unless it's a new service recipient that is not transitioning from the PCA program. Consultation services are lengthy and difficult for people to sit through and usually have to be split into at least 2 sessions. It is a lot of new information to process and new decisions to make that are usually scary and confusing and cause a lot of resistance from people due to very limited awareness prior to the consultation session. Overall, it takes about 3 to 6 hours per client to write a meaningful service delivery plan that client is willing to move forward with. Another barrier is the interpreting services for people who speak limited to no English. It is very costly for the consultation provider to accommodate scheduling and voicemails for the languages that are not spoken in the office. Interpreting agencies are only able to charge insurance carriers for the billable visits, like the sessions themselves, but scheduling and voicemail assistance has to be paid for by the consultation provider out of pocket at the market rate. Moreover, medical assistance only allows interpreter billing for in-person consultations, and therefore providers have to pay out of pocket for all the interpreting services during remote sessions. It would be very greatly appreciated if the reimbursement for consultation services would be revisited and if the interpreting services could be provided through a free language line similar to what's available to MNsure navigators. Thank you, and I'm happy to answer questions.
Thank you for your testimony. First up, Senator Gruenhagen.
Oh, thanks. You know, if I understand correctly, Houston, we have a problem. No, thanks, Mr. Chair. So there's 946 providers, only 326, if I understood that correctly. 320 have been approved. And because of that, even with the 6-month delay, it's causing disruption in the relationship between the disabled and their provider. Did I understand that correctly?
Chair Hoffman
Ms.
and
Garretts?
Senator. Sorry, Chair Rasmussen. So that 6-month temporary authorization certainly helped. The 2 agencies that I support, one just got coded last Thursday. We did a big celebration. The other one is not yet coded. So when that person is to transition, we get an additional 6 months of PCA. And so during that time frame, that 6 months, that's when they're to meet with the consultation provider. So they're continuing to get their services until they can get with the consultation, develop the plan, and then get a CFSS authorization. So it was a 3-month temporary authorization, but because of feedback, DHS did extend it to 6. We're hoping that's enough time, but will the rest of those providers get coded by then? We don't know. So,
Senator Gruenhagen,
Oh,
follow
thank you, Mr. Chair, yeah. You're helping me understand this. I appreciate it,
Yeah.
both of your testimonies. So to me, you should be able to give feedback to those agencies who should make accommodations not to interrupt the services for the disabled individual. Is that happening?
yes.
Ms. Kurtz?
Chair Rasmussen, Senator. Yes, I mean, we've had meetings with DHS about this process, and certainly the Provider Alliance, the Minnesota Home Care Association have been working with their members to understand this process. There is a process where if there's a brand-new client that wanted to come to our agency, one of the agencies I support, we were able to call DHS and ask them to expedite our enrollment process. Doesn't always happen. I mean, I know Hmong Home Care has done that, but they're still not coded. but we're able to get temporary authorization so people can get services. And that's been the biggest concern, and I think what all of us have been working on is making sure there's not a gap in service.
Just one more quick question.
Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, so does the agency provide waivers in situations where there's a new person coming up or where you're having a disruption of services due to not being certified? I mean, do they waive requirements for, so that this person continues to receive some type of services?
Ms. Garretts.
Senator, or Chair Rasmussen, Senator. So if it's a brand-new person, I know we, at one of the agencies I support, they were able to get a temporary authorization. We went through all the same process. The employee has to get the background study, do the training, all those kinds of things. And then we were able to pay the worker, but now we'll be able to bill now that we've been coded and get actual authorization. So we have made some accommodations for people coming on prior to us being coded as an agency. Again, our greatest concern is making sure people get the service.
Just one last comment is
Yep.
that,
Senator
it's not
Gruenhagen.
a question. Thank you, Mr. Chair. I mean, I just hope that the agency will work with the provider to limit the amount of disruption of services, and if it takes a waiver for a period of time, that is accommodating. I mean, nobody wants to see a disabled person get disrupted their services or provider due to some new program that hasn't yet transitioned or in the middle of transitioning. So I don't know what the rest of the members think, but I think that's just my initial thought.
Senator Abler.
Well, and we have two bills up we have to move to at some point, but this has been a really productive discussion, I think, and I just have I was doing pretty well until I heard about the 63% are Black, Indigenous, and people of color, particularly with challenged English. Now, take my story, and now this person, English is her second language, and the child who, this program needs to be paused, is what it needs to be. Until we can get good training, no assessor should tell somebody that they can't use that provider. And so I told Alex Bartalik this back in those days. I said, if everybody was as good as you folks, if they knew what you knew, there would be no problems. But the transition from what you all know, and you put in your bulletins, what gets trained into the furthest flung assessor, subcontractor, whoever, who should be something else, but nobody controls those assessors when they're subcontracted except for the agency that's doing that, and maybe they're not a very good one, and now they're disrupting these lives. And so there's a whole gap from the accountability to the subcontracted assessors, where the counties have written them off from even worrying about them. But this is unacceptable, and I'm very worried. And so, Mr. Chair, you can have, there's not enough consultation people, there's not enough providers. The provider access is too hard. If you have a good provider like these, 90% of them are, only a few percent make headlines. If you have a 90% group of good providers, have them like check a box. Here, oh yeah, perfect, you're in. That's how I would do it. And then you'd have none of this going on, where these people, you can just tell. I can give this to the department if they want the form. Anyway, so, Mr. Chair, thank you. I just don't get it. And you mean well, but it's a complicated program with complicated things, and you're asking assessors to get $100 for 3 to 6 hours of work and pay for an interpreter? Who would sign up to do that job? And thank goodness there are people that do it. But I don't mean to be ranting, but I'm just, this might have been the bill I carried in 2012, and I'm sorry.
So up next, and thank you very much for your testimony, up next we have a bill from Senator Boldon, Senate File 1175. Senator Boldon, welcome to the committee. And if we could also have Senator Boldon's testifiers, Ms. Barnes and Dr. Berry, also make their way to the front, that'd be great. Thank you. And Senator Boldon, it's my understanding that you have the A1 authors amendment. Would you like that moved at this time?
Yes, please, Mr. Chair.
Thank you, Senator Boldon. Senator Hoffman moves the A1 amendment as an author's amendment. All those in favor say aye. Aye. All those opposed say no. The A1 is adopted. Senator Boldon, to your bill as amended.
Thank you, Mr. Chair. Thank you, committee members. I am grateful to be before you with this bill. This is a bill that connects presumptive eligibility for Medicaid with positive newborn screening results to ensure that infants with urgent medical needs can get immediate care. This really is about ensuring that patients can get the care that they need. It also will reduce delays in treatment that could lead to severe health complications or death. And it facilitates hospital decompression by allowing faster discharge of patients who need long-term services and supports, ensuring they can transition to appropriate care settings without unnecessary delays. So when we are talking about presumptive eligibility, what does that mean? We have an existing hospital presumptive eligibility program that permits participating hospitals to enroll patients in medical assistance with basic information like income and household size, which ensures quick access to care. And so it allows that immediate temporary Medicaid coverage for children and pregnant women while their full application is processed. So this bill is looking at just expanding that program that already exists based on newborn screening. And so newborn screening, and Minnesota is a national leader in newborn screening. We test for over 60 conditions that, if left untreated, can cause illness, profound disability, developmental delays, or death. So it is really important for that early intervention and that early care for these newborns. So this bill would do three things. It'll have impacts by providing immediate access to care. So infants who test positive for congenital or heritable disorders, as I mentioned, often require urgent medical intervention. So this presumptive eligibility would ensure that they receive timely delivery of care without unnecessary delays. These children would otherwise qualify for disability services. This just streamlines that care, streamlines that process. It'll improve health outcomes. We know that early intervention is critical for infants diagnosed with severe conditions. So by facilitating that prompt access to medical assistance, we can improve survival rates and long-term health outcomes. And lastly, it will enhance healthcare efficiency. Streamlining the eligibility process reduces administrative burdens on hospitals and healthcare providers and allows them to focus on patient care rather than bureaucratic outcomes. So I will pause there and have some testifiers that can speak more to this and the details of this. I also just want to thank my bipartisan co-authors who are also supporting this bill. Thank you, Mr. Chair.
Ms. Barnes, welcome to the committee. Please introduce yourself, state your name for the record, and proceed with your testimony.
Chair Rasmussen and members of the committee, thank you for the opportunity to testify in support of Senate File 1175, which allows hospitals to establish presumptive eligibility for Medicaid on the basis of a positive newborn screen. My name is Erica Barnes, and I'm the Minnesota Rare Disease Advisory Council Executive Director. The Minnesota Rare Disease Advisory Council is an executive branch state agency whose mission is to provide advice on improving care for the 1 in 10 Minnesotans living with a rare disease. We organize our work around 4 priority pillars, one of which is reducing the time to a rare disease diagnosis. Within our function as an advisory to other governmental agencies, we believe that working with MDH and DHS to strengthen our newborn screening program through both disease identification and efficient follow-up care is critical to making progress on this pillar. So that's why we support this bill. Since its establishment in 1966, newborn infant screening has grown into one of the most successful public health initiatives in the U.S., saving countless lives and averting significant healthcare costs. Each year, greater than 98% of the U.S.'s newborns are screened, and over 12,500 are diagnosed with a serious health condition. In Minnesota, between 2017 and 2023, 763 newborns were identified with a heritable or congenital disorder that required urgent intervention. And these numbers will continue to grow as medical advancement for rare diseases continues at an unprecedented pace, allowing us to add more rare diseases to our newborn screening panel. Researchers right here in our state are discovering cures and treatments for rare diseases that were once considered outside of the scope of medicine. For some of these diseases, the cruel irony is that once symptoms begin to appear, which is the typical pathway for diagnosing, the child has lost the window of opportunity for any sort of treatment. Newborn screening is quite literally their only hope of survival. But early identification is only the beginning. Proactive follow-up and timely delivery of intervention is vital to avoid a lifetime of disability or even death. And any delay, such as a lack of clarity around insurance coverage as families navigate both the birth of a child and the unexpected diagnosis, can have catastrophic consequences. Due to the rigor of adding a disease to the newborn screening panel and the criteria a disease must meet, the Minnesota Rare Disease Advisory Council believes that a positive newborn screen is a strong proxy for identifying children who will qualify for Medicaid through a disability determination. But this disability determination process takes time. Allowing hospitals to presume eligibility for Medicaid immediately while waiting for the final disability determination will expedite delivery of care to these children and ensure that no child misses the window for life-giving treatment. This piece of legislation streamlines an already complex and traumatizing process for families. Families who have a child with a life-threatening disease deserve the right to focus all of their energies on saving that child's life. Let's support these families by taking away an administrative hurdle so that they don't have to take away the focus on their child. Thank you.
Thank you, Ms. Barnes. Dr. Berry, please welcome to the committee. Please introduce yourself and proceed with your testimony.
Thank you, Mr. Chair. Good afternoon to all of you. My name is Susan Berry, and I'm a professor of pediatrics at the University of Minnesota, and I'm the director for our Rare Disease Center of Excellence. But perhaps more important in this context, I'm a doctor, I'm a physician that specializes in medical genetics. And one of my major responsibilities is to care for children with genetic conditions, particularly babies that are identified by state of Minnesota newborn screening. I'm here today to speak on behalf of this bill, particularly this element that talks about facilitating medical coverage for an infant with a positive newborn screen and all the things that go with that. Because these children urgently require diagnostic testing and treatment. So newborn screening is designed to detect serious and often life-threatening conditions that are found in children that are not physically evident in the first days of life. That means the baby comes to you, they look fine. And so it's always a shock and a surprise. The priority is to identify conditions that need early treatment, sometimes urgently so, to prevent disability or death. And this is so important that pretty much all Minnesota babies are screened in hopes of accomplishing a prompt diagnosis and effective treatment. If a screen indicates the presence of one of the target disorders, we need to act quickly to confirm the diagnosis and, more importantly, to begin treatment. And in some cases, this means a change in diet. That sounds pretty simple, even though it's not, because it requires special foods and a lot of education. In others, however, the therapy is more difficult, and it may require expensive medications or procedures. For example, I'm going to give you a specific example. Our skate happens to be one that screens for a rare but devastating condition called Krabbe disease. This is an awful condition where a baby looks, of course, perfectly normal at birth, but in the first months of life without intervention begins a rapid deterioration in their nervous system that ultimately leads to death. The only treatment that's found to have an impact on this is a bone marrow transplant, but this is the hard part. The transplant has to be done before they're 30 days old, or there's basically not much effect of the treatment. It doesn't help very much. And so the timeline to get that done within that 30 days, after you've had 7 days to get the tests done and get the results back, and we don't have much time to make that work. And families often don't have any kind of assured health care for their child at that time frame, much less the ability to accomplish that while they're dealing with the trauma of this diagnosis and making informed decisions about a treatment that is in itself difficult. So unfortunately, most of these kids, of course, are ultimately going to qualify for Medicaid. But as Erica mentioned, the lack of clarity can cause them to be delayed, to delay the initiation of therapy, to delay the opportunity to undertake this life-saving treatment. So I'm going to get all preachy here. It's really wrong It's wrong to strain for treatable disorders as a public health measure and then have a family be unable to begin the only possible life-saving intervention because they don't have the financial means for treatment. That's just wrong. So this revision allows us to know that we can promptly diagnose these children that are identified by our own newborn screening program without a family risking delaying diagnosis and treatment for financial reasons. The revision will relieve families of that impossible dilemma and allow them to focus on working with their doctors to make the best plans for their child's care. So I urge your support for this important provision in the legislation. Thank you.
Thank you. Any member discussion? Senator Maye Quade.
Thank you, Mr. Chair, and Ms. Barnes and Dr. Berry. I want to thank you for coming and testifying today, and Senator Boldon for your bill. I just sent you an email hoping to be that 5th co-author. There is not much I think about more than those first few months with having a baby. It was not that long ago. It was like 2 years ago. And I can't imagine like adjusting to the world and then also getting a terrible diagnosis and then trying to navigate applying for MA. And so I just, whatever we can do, because, you know, these are people who are going to be on MA. It's just how fast. And that is probably going to determine their quality of life and potentially, you know, we're also a budget committee, savings for care in the future. And so this is just one of those things that comes through and you're like, who could oppose this? So I'm really grateful to you for bringing this bill, and I'm hoping to be that 5th co-author. Maybe you'll have to make clones, but I appreciate you coming in today.
Senator Abler.
Thank you, Mr. Chair. Actually, I was thinking the same thing, so you win, Senator Maye Quade. So anyway, I think it's a really interesting idea, and I actually wasn't even aware that this was one of the ways that MA, people get into MA. And so I suppose if you, maybe there's a cost, I don't know, but they'll figure that out. But it seems if they're going to get there anyway, I just wonder, do you know, so they do the test, they find one of these conditions that the bone marrow transplant will fix, but they have to get going on it. And so they do their newborn test and they come back, hey, I got bad news, your child has this condition. Are there people that don't get the treatment because their regular insurance doesn't cover it in the meantime, that this would solve this problem? Do you know, does anybody know that?
Dr. Berry?
So I will say that this disorder that I'm describing to you is extraordinarily rare. They're all rare diseases, but this one's really rare. So it's not like we're going to have had 50 cases to give you information about. Since we started screening for this disorder, really only identified one child.
Yeah.
And that child did accomplish getting a transplant within 30 days, and it was everybody, all hands on deck to get it done. So is there a family that might be in this situation? Yes. For that particular disorder, it's a theoretical possibility. For others, it's not so theoretical. Babies who are in, for example, religious isolates where they don't necessarily have access to public assistance all the time, we sometimes struggle to get those children tested because they don't have any real means for the medical care that they need. They have to pay out of pocket. There are other families where they just don't go ahead and get the diets that they need because it's not covered by insurance.
Yeah.
So it's a problem for the work that we do.
Senator Abler.
I'm just more curious, and I don't want to drag the day out with my curiosity, but I've always favored the newborn screening. We've added more and more tests, and I think the people pay on their own, don't they, at this point? And the people on medical assistance.
It's usually bundled in the hospital bill.
Yeah, yeah. So it comes out of their pocket somehow. But and so a person who has a disability gets covered here under current law. But so do you have to wait till they look like they're, at this point you're doing this, if they have the condition, they're considered to have a disability. But so under current law, the current practice would be they actually have to have some effect of it that would get them into a category of expressing that disability. Is that what we're fixing, Senator Boldon or the
Ms. Barnes?
testifiers?
Ms. Barnes?
Chair Rasmussen, Senator Abler. So Yeah, currently, and so I'll speak to kind of building on what Dr. Berry said. I would agree that in terms of coverage that commercial payers sometimes don't cover, I know the one that did come to mind was medical foods. So some of these children do require specialized foods, and sometimes the commercial payers don't cover that. I will say that Medicaid is a payer of last resort. So one of the really important parts of this bill is it's not expanding Medicaid per se. It's really, again, covering what Medicaid eventually will pay for these children. What families have to do when they get this unexpected diagnosis is they have to start the SMART process, the disability determination. And eventually, yes, remember these diseases that we're picking up on newborn screening are devastating, complex diseases that, you know, eventually they do qualify, but it's just the timeline and the process and the lack of clarity for the families. And as Dr. Berry said, I hear on a regular basis doctors saying, you know, contacting me desperately saying families don't have clarity and so they're delaying and they don't understand how devastating these diseases are. So.
Thank you. Senator Abler.
It just seems like I like the idea. Can you put 6 people on a bill? But so, especially with the money on this thing, if Medicare, if they're the payer of last resort, then their insurance would cover it anyway, but at least that way now they have the backup and they would feel confident. And I've met with, over the years, Jeremy Miller has done a lot with this, Senator Miller, and to learn a little bit. It's a really good we're doing that. So anyway, I'll leave it at that.
Senator Rucky.
Thank you, Mr. Chair. And just a curiosity question, as you were talking about some of these babies and the rare diseases, et cetera, how many young people like that do we have per year that are born with these issues, as just to kind of get an idea of the quantity or the number of people?
Ms. Barnes.
Sure, Chair Rasmussen, Senator Utke. So we pick up about, so the number from the MDH website is about 109 newborns each year on average that we're picking up with these congenital diseases. I will really emphasize that part of the hope of this bill is we anticipate that we will see more and more rare diseases added to the newborn screen because there is so much research and innovation going on in rare diseases. So currently it's around 100 children, but we also want to prepare for all of the wonderful innovation that's happening in these. We'll be able to identify even more kids. So that number will probably increase, although they're rare, so.
Thank you. That was it. Appreciate it.
Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, thanks for your presentation, and we definitely want to get the care there as quick as possible, it sounds. So do you have this type of delay under, if the people are covered by private insurance too, or is it just with Medicaid?
Yeah.
Dr. Berry.
Well, when your baby's born, they don't automatically go on your insurance. And so it's often a situation where a family won't, I mean, they will get the kid added, but there's no insurance in force at that moment. And suppose people start scrambling to make sure that things are covered because, as you might be aware, all hospital care and all medical interventions cost money that people don't have in their pockets. So yes, do families have that uncertainty even with private insurance? Unfortunately, yes, they do.
Senator Gruenhagen.
So if I understand you correctly, medical professionals will withhold care until they're certain that they...
No.
No, they won't.
No, no, they don't withhold
Excuse me,
care. They
Dr.
come
Berry.
to clinic, we do our thing, we get their formula, we have the closet full of stuff.
All right.
They get seen.
And all this will do...
All of this happens.
Senator, I just would remind folks if you could wait until I call you, that'd be great.
Yep, okay.
Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, so the care is going to be there. All this will do is expedite it in a much quicker way so that they get approved for some reimbursement at a much more timely rate. Because I just can't see medical professionals not given the care that they know is needed. I mean, so anyway, that's it.
Thank you, Senator Gruenhagen. Any further member discussion? Seeing none, Senator Abler moves that Senate File 1175 as amended be recommended to pass and be re-referred to the Committee on Health and Human Services. All those in favor say aye. Aye. All those opposed say no. The motion passes, and the bill will be sent to Health and Human Services. Thank you, Senator Boldon.
Thank you.
Up next, we have a bill from Senator Maye Quade, Senate File 985. And if we could have Senator Maye Quade's testifier, Ms. Tram, come up to present, that would be greatly appreciated. Please find a seat at the testifier's table. And Senator Maye Quade, it's my understanding you have a A1 author's amendment, is that correct?
No.
You do not? Got it. We'll wait, Senator Grunegan. So, Senator Maye Quade, please present your bill and welcome to the committee.
Thank you so much. Feels good to be in front of this committee, a verbose committee. Before you today, Senate File 985, which will provide $4 million in one-time appropriation to LifeWorks Services for a statewide disability inclusion pilot program. LifeWorks has identified that businesses, healthcare providers, and general support services are not meeting the requirements outlined in the Minnesota Human Rights Act for the 1 in 4 Minnesotans who have a disability. People with disabilities are one of the largest minoritized groups in Minnesota, and they encountered barriers every day, including language, transportation, economic stability, cultural and racial bias, and social isolation. With this appropriation, LifeWorks is working to be part of the solution. In 2024, LifeWorks conducted community conversations, listening sessions, surveys, and disability inclusion trainings. Over 4,000 people were heard, and over 1,200 people were educated on disability inclusion. LifeWorks learned the following. Rural Minnesotans feel left behind. Lack of education, services and providers, transportation and technology accumulate massive barriers for people looking for support. The disability community, family, caregivers, and case managers, service providers all want more education. What services are available and how to access them is a significant barrier, particularly for children and for elders. And community members experience a lack of dignity through their interactions with healthcare providers, businesses, community spaces, and the social service system. Destigmatizing disability was discussed each time. From these discussions and trainings, LifeWorks Disability Inclusion Pilot Project will persuade employers to hire more workers with disabilities, educate businesses on the economic benefits of inclusive employment and offering accommodations, educate Minnesotans with disabilities and their families on navigating services and achieving inclusion in their communities, build capacity to support rural and tribal communities, co-create services requested by communities, invest in safe community-focused spaces to host education sessions and support, and launch a statewide disability inclusion assessment for businesses and community spaces to improve accessibility and inclusion. As we continue to build an inclusive society where we can each live and thrive, this program will build capacity and systems to ensure all Minnesotans can access services, programs, and support. And I hope to earn your support for this program. I'll turn it over to my testifier and just turn your attention to the letters of support in support of the bill, one from a community member and then one from the Vice President of Human Resources at Building Flow Solutions, which is also in Apple Valley, who has done some really great work around education and inclusion at their business.
Thank you.
Welcome to the committee. Please introduce yourself and proceed with your testimony.
Thank you, Chair Rasmussen and members of the committee for this opportunity. My name is Kiri Tram. I'm the Director of Disability Initiatives at LifeWorks Services. I'm also an autistic professional dedicated to advancing disability inclusion. While supporting people with disabilities is often seen as an expense, I want to share how this bill would fund essential work to make Minnesota a leader in disability inclusion, because the truth is, disability inclusion benefits us all. At LifeWorks, we have seen firsthand how educating businesses and communities about disability inclusion transforms workplaces and public spaces. According to a study by Accenture, employers who embrace disability inclusion reduce turnover and outperform their competitors in revenue and profit. One business representative told me recently, as we're updating our processes for employees, we're actively thinking back to the disability inclusion training from LifeWorks to make sure all of our employees can bring their best selves to work. People with disabilities also tell us how inclusion is changing their lives. When communities remove barriers and offer choice, people gain access to meaningful jobs, social connections, and independence. One person shared with me, "It's wonderful to know that I'm not alone." But this work isn't just for people with disabilities today. It is for all of us. Disability is the one identity that any of us can join at any time in our lives, and most of us will experience a disability in our life. If Minnesota becomes the first disability-friendly state now, we'll ensure that we remain welcoming, accessible, and prepared for our collective future. The pilot project this bill would fund is an opportunity for Minnesota to lead the way in disability inclusion, setting a model for other states to follow. By investing in this effort, we're not only expanding opportunities for people with disabilities, but we're also strengthening our workforce, our economy, and our communities. Thank you.
Thank you. Senator Gruenhagen.
Oh, thank you, Mr. Chair. Yeah, thanks for the presentation. Yeah, I have the A1 amendment. I think it's included in your packet.
Senator Gruenhagen moves the A1 amendment. It's included in members' packets. Senator Gruenhagen, to your amendment.
Basically what it does, this amendment asks LifeWorks to submit a plan to DHS before getting paid. That includes specific goals and outcomes of this pilot program and how they plan to achieve them. You know, I read the letter that was included in our packet by LifeWorks, and to me, they pretty much have laid out what their goals are in terms of what they're trying to reach with this pilot program. So it'd be a relatively simple report to put it in a documented way so that we as legislator in 2 years could see what the actual results were. The amendment also requires DHS, with the help of LifeWorks, to submit an effectiveness report to the legislature that includes a summary of outcomes, how the money was spent, and the progress they made towards achieving their goals. And members, we've had, and I've heard LifeWorks does excellent work, okay? So I'm not here to disparage them in any way, but we have had in other areas quite a bit of less than perfect results, let's put it that way. Okay, the report would be due February 1, 2027, which is on line 1.20. I respect the work that LifeWorks is attempting to do with this program, and this amendment will help us see the progress they are making since it's a pilot program if we want to expand it or continue it. It also ensures that the parties are aware of the goals in order to help achieve the desired outcome. By reporting the progress and results to the legislature, we can then take the information and look to see if it should be expanded. I'm hopeful that Senator Maye Quade would see this as a friendly amendment.
Senator Maye Quade.
Thank you, Mr. Chair. I don't see it as an unfriendly amendment, just a redundant amendment. I think we passed in 2023 language that directs the MMB, MDH, DHS, and DCYF to create, review, and revise performance measures, data collection, and program evaluation programs for all state-funded grants that are $1 million or more. And then I think we updated that language last year. And I would look to council to just say, I guess what I don't want to do is do less because it's prescribed here instead of what was created. But yeah.
Mr. Monahan, to the question on if the A1 would be more or less prescriptive than what current statute requires?
Mr. Chair, members, I'm going to have to plead ignorance. I have no recollection of that change. So,
Senator Maye Quade.
Thank you, Mr. Chair. 16A.055 subdivision 1B, I believe, is the statute there.
Senator Abler, to the amendment.
Well, thanks, and I'm not aware of this amendment. Maybe I missed a meeting or something, but I think there may be somewhere to go with this. I don't feel like I'm in a position to vote yes or no on this, but this committee has been pretty collaborative in this approach, and so I don't know if Senator Gruenhagen, if you're willing to just for now not to withdraw it and work with Senator Maye Quade and see if there's something that we can agree on. Just frankly, the effort to fund a program like this is going to be really hard anyway in this world. But I know what you're after, and I support the intent of it. But just given that this is like one of the few, I mean, we're kind of like a good collaborative committee. I think we should keep that up. And so if Senator Maye Quade will agree to chat with Senator Gruenhagen, I'm willing to ask him to wait. So thanks.
Senator Maye Quade.
Thank you, Mr. Chair. I would totally agree to that. And I think, I'd want us to be clear on what is in law and what isn't, and I have no problem with the purpose of this amendment, and so would support, doing all of that work if it comes into an omnibus.
Senator Gruenhagen.
Yeah, I'll withdraw the amendment, and maybe council could verify if there is a report back to the legislature, what it would document and how it would conflict or not conflict with be a part of what this amendment is getting at.
Senator Gruenhagen.
So I'll withdraw it at this time. Is council willing to do that?
Senator Gruenhagen withdraws the A1 amendment, and I'd encourage Senator Gruenhagen to follow up with Senate Counsel. Any further
Mr. Chair,
discussion?
I
Senator
would
Gruenhagen.
ask council to do it on a pro bono basis.
Any further member discussion? Senator Abler.
Well, and this business about disability inclusion, Senator Hoffman has done quite a bit of work, as I have a little bit with the agencies, trying to get them to include, and we were pretty shocked about how marginally the different agencies have been about including people as we so thought they ought to. So the idea has merit, and I'm setting you up for an easy comment if you want, Senator Hoffman. Otherwise, that's all I have to say.
Senator Hoffman.
Thank you, Mr. Chair, and thank you, Senator Abler. Yeah, we've had the multiple conversations. That's exactly why. It gets to the why we do what we do here in this committee, right? And it's to have that conversation focused on the end on doing this. Thank you for bringing this forward. This is why we exist, I mean, I'll never forget Josh Berger. This is why we do what we do. So thank you for getting us to the why. I appreciate you.
Senator Mohammed.
Thank you, Senator Maye Quade, for bringing this, and it's a good bill. I think it'll do good work, so hopefully we find the funding to do this, Chair Hoffman and Chair Rasmussen, and I'd like to co-author.
Any further member discussion? Seeing none, Senator Maye Quade. Any closing
Thank you,
comments?
Mr. Chair. Thank you. And Senator Mohammed, there is space for you on this bill for sure. And I want to just really give a shout out to LifeWorks. I have a LifeWorks in my district. There are bills that you do the work on, and you are hammering it out in meetings and tweaking language and coming before, and then there's bills where you get to bring the work forward of really, really good people, and that's this bill. And so I'm really appreciative to LifeWorks and all the work that they've done. I'm really proud to carry this bill for them. So thank you. Thanks.
Senate File 985 is laid over for possible inclusion in the omnibus bill. Just wanted to, for the public, next Monday, this committee will be receiving the governor's budget overview with MMB and DHS for the relevant portions of the budget for this committee. And then next Wednesday, a week from today, we'll be allowing testimony for providers, advocates, and any other interested parties who would like to respond to the budget proposal. And with that, we are adjourned.
Thank you.